Dr. Zaher Kasih, well-known interventional cardiologist, American boarded. He is in the private sector and consultant in the University of Jordan. Please, Dr. Zaher.
شكرا جزيلا. السلام عليكم. Can we present the slides, please? Okay, I'll be talking about hypertension with heart rate, risk factors, and treatment choices. This is a typical patient. He's a 37-year-old male with hypertension, blood pressure 150 over 100. He's banker. He has moderate physical exercise. His BMI is 27. His heart rate is relatively high at 96 beats per minute, and he has an A1C of 5.4. And this is his lipid profile. You can see that he has a high LDL, and this is his HDL, which is quite low. He's married, and he's on atorvastatin 10 milligram. Now, what is sympathetic overdrive? Sympathetic neural factors are involved in multiple hemostatic functions, including energy balance and blood pressure control. Chronic sympathetic activation or sympathetic overdrive has been implicated in the development of metabolic syndrome and other cardiovascular risk factors. Sympathetic overdrive is triggered by a reflex mechanism, that is arterial baroreceptor impairment, as well as metabolic factors, that is insulin resistance, and humoral factors including angiotensin 2 and leptin. Sympathetic overdrive is associated with increased heart rate and multiple cardiovascular risk factors. As you could see here, with sympathetic overactivity, there will be arteriolar constriction, reduction in muscle blood flow, as well as an increased oxygen consumption with possible ventricular arrhythmias. Increased heart rate would be associated with increased artery wall stress, endothelial dysfunction, and the possibility of accelerating atherosclerosis. Also, there would be left ventricular stiffness, left ventricular dysfunction. Now, the end result would be an increased probability of coronary events, sudden death, and heart failure. Sympathetic overdrive plays a key role in the pathophysiology of cardiovascular disease. With increased sympathetic nervous activity, there will be neural release of norepinephrine. With beta-1 receptor stimulation, there will be an increase in heart rate, reduction in heart rate variability, and increased contractility. There would be mechanical and vascular damage with pulsatile stress on vascular system, augmentation of atherosclerosis, plaque rupture, and risk of cardiac ischemia. Also, with beta-1 receptor stimulation, there will be an increase in renin release, increasing angiotensin, increase in blood pressure, increase in left ventricular hypertrophy, and eventually heart failure. Sympathetic overdrive leads to multiple responses that contribute to heart failure and sudden death. With sympathetic nervous activation, there will be an increase in heart rate, increase in the renin, angiotensin, aldosterone system activation, reduction in myocardial reserve, reduction in myocyte contractility, reduction in coronary blood flow, electrolyte abnormalities, progressive cardiac remodeling, and cytokine activation, eventually leading to vasoconstriction, ischemia, increasing arrhythmia risk, cardiac dysfunction, and the possibility of heart failure and sudden death. Diabetes can activate the sympathetic nervous system. Type 2 diabetes is associated with increased insulin resistance. That is, an increase in insulin would be associated with an increase in norepinephrine release, eventually leading to ventricular arrhythmias, increasing plasma renin activity, increasing angiotensin 2, thus leading to beta-1 adrenergic stimulation, increased blood pressure, and non-dipping at night. Now, this is to show the sympathetic activity the sympathetic activity being elevated in patients with diabetes mellitus and hypertension. The combination in the left panel of essential hypertension plus diabetes is associated with increased sympathetic activity, and this is more than just having essential hypertension and more than just having diabetes, and this is more than normotensors. Stress activity also activates the sympathetic nervous system. Obesity activates the sympathetic nervous system, particularly central obesity, that is central adiposity, which leads to increased production of vasotoxic adipokinins, including tumor necrosis factor alpha and interleukin-6, also increased endothelial inflammatory response and increased production of leptin, with the eventual endothelial dysfunction and insulin resistance, and eventually activation of the sympathetic nervous system. So obesity is associated with increased sympathetic nerve activity, particularly when there is a central obesity as compared with peripheral obesity. Also, smoking can stimulate sympathetic nervous system through the action of nicotine with stimulation of sympathetic ganglia, release of norepinephrine vasoconstriction, increase in peripheral resistance, increasing heart rate and blood pressure. Smoking is associated with a 2 to 3-fold increase in norepinephrine release, in norepinephrine and epinephrine release. And the underlying causes of hypertension differ between the young and old. Out of the Framingham Heart Study, you could see that in the young patients, particularly with male sex, high BMI at baseline and increasing BMI during follow-up, in these patients, the main mechanism of diastolic hypertension and systolic diastolic hypertension is raised peripheral resistance. While in the isolated systolic hypertension, the predictors include old age, female sex, increasing BMI during follow-up, and only 18% with new onset isolated systemic hypertension, they have previous diastolic blood pressure more than 90. The main mechanism for these patients with isolated systolic hypertension is increased arterial stiffness. Now, this is to show that increased heart rate is a long predictor of cardiovascular events in patients with hypertension. There's a 53% difference in the incidence of endpoints if you compare patients with high heart rate, uncontrolled blood pressure, compare that with low heart rate and controlled blood pressure. Sympathetic overdrive is a key driver of elevated heart rate and leads to increased risk of cardiovascular mortality. You could see that as the heart rate increases, there is increase in coronary heart disease as well as cardiovascular disease mortality as a function of increasing heart rate. And this is out of the Framingham Heart Study. And out of a French study, again, it showed that elevated heart rate increases the risk of mortality in young men. If you compare heart rate of between 60 and 80 to that between 80 and 100 and more than 100, you can see that there's an increase in cardiovascular death and cardiovascular disease. Elevated resting heart rate increases the risk of sudden death in middle-aged men, again as a function of increasing heart rate. And there is a link between sympathetic overdrive and the risk of cardiovascular death demonstrated in patients with type 2 diabetes. You could see the function of increasing heart rate and cardiovascular death in diabetic patients. Elevated heart rate, pharmacotherapy in the management of elevated heart rate options include blocking the beta receptor, especially in beta blockers without intrinsic sympathomimetic activity. These agents, they have direct effect on the beta receptor, direct effect on the sympathetic overactivation. While if you compare that with non-dihydropyridine calcium channel blocker, the action is not related to sympathetic overactivity, but related to nerve conduction blockage. And the F channel blocker, ivabradine, the action is really is a specific action on the F channel that controls the pacemaker activity in the sinoatrial node. So the only agent that really has an action, a direct action on the sympathetic activity is the beta blocker, particularly the cardioselective beta blockers without intrinsic sympathomimetic activity. So you could see here that if you compare beta blockers, particularly those with selective beta blocker, you could see that with selective beta blocker, you have reduction on the peripheral and the cardiac sympathetic nervous system. If you compare that with the calcium blockers, the short-acting calcium antagonists in red, they have marked increase in peripheral sympathetic stimulation as well as cardiac sympathetic stimulation. Beta blockers protect the heart at every stage of the cardiovascular continuum. And actually, highly selective beta blockers inhibit sympathetic activity in the heart and kidney, preserve beta-2 mediated vasodilation, and reduce the risk of adverse effects mediated by blockade of beta-2 receptors in the lungs and peripheral tissues. Beta-1 blockade may be particularly beneficial in hypertensive patients with central obesity, diabetes, and insulin resistance. You could see that they block the effects that lead to ventricular arrhythmias, that lead to beta-1 stimulation, that lead to increased beta blocker and non-dipping at night. And you get beneficial effects that are mediated by blockade of the beta-1 receptors. Now, as compared to ACE inhibitors, over years it was found that beta blockers can reduce mortality in the overweight, obese, and high-risk hypertensive patients with type 2 diabetes. And looking here at bisoprolol, which is a selective beta-1 receptor, you could see here that out of the European 2013 guidelines, it says that blood pressure measurement should always be associated with measurement of heart rate because resting heart rate values independently predict cardiovascular morbid or fatal events in hypertension. It is that diuretics, beta blockers, calcium antagonists, ARBs, and ACE inhibitors are all suitable for the initiation and maintenance of antihypertensive treatment. Also, the nice British guidelines, they say that the initial therapy of hypertension in younger people, beta blockers, they should be used, particularly when there is evidence of increased sympathetic drive, and in those with an intolerance or contraindication to ACE inhibitors or ARBs, and also in women of childbearing potential. The Canadian guidelines also, they recommend beta blockers, particularly in patients aged below 60 years of age, and this is a grade B recommendation. Now, bisoprolol is indicated for hypertension, coronary artery disease, angina pectoris, and chronic heart failure. And bisoprolol has a balanced clearance between the kidney and the liver. So actually, there is no interaction. There's no dose adjustment necessary in mild to moderate liver or kidney impairment. Beta-1 selectivity of different beta-1s, you can see here that bisoprolol is a highly selective beta-1 blocker if you compare it with atenolol, betaxolol, and metoprolol. Again, bisoprolol has the beta-1, beta-2 selectivity is in favor of bisoprolol as compared to betaxolol, metoprolol, atenolol, and carvedilol. Now, there's more effective 24-hour blood pressure control with bisoprolol as compared to atenolol after once daily dosing. And also, bisoprolol was significantly more effective in reducing systolic blood pressure and diastolic blood pressure during the final 4 hours of dosing interval. Let me skip that. This is to show the comparison between bisoprolol and nebivolol, the cardioselective vasodilator beta blocker, to show that they have similar effects concerning 24-hour blood pressure control. And bisoprolol is superior to other antihypertensive therapies in middle-aged hypertensive male. And again, if compared to atenolol, it showed more selective control. Again, bisoprolol, the beta-1 selectivity, as compared to atenolol, you could see here that concerning the airway resistance, it does not have, bisoprolol does not have any bad effects on the airway resistance as compared to atenolol. I will skip that. I will go to the summary. Sympathetic overdrive in hypertension, the role of beta blockers with focus on bisoprolol. Sympathetic overdrive is associated with the development of multiple cardiovascular risk factors and is the main cause of hypertension in young and middle-aged men. Sympathetic overdrive leads to elevated heart rate and increases the risk of cardiovascular mortality, particularly in middle-aged men with hypertension and or diabetes. The adverse cardiovascular outcomes associated with sympathetic overdrive result from the neural release of norepinephrine and stimulation of beta-1 receptors in the heart and kidneys. Beta-1 blockade helps to prevent the adverse effects of sympathetic overdrive and could protect the heart at every stage of the cardiovascular continuum. Beta blockers are recommended in treatment guidelines for the initiation and maintenance of antihypertensive treatment. And bisoprolol is a highly selective beta-1 selective beta blocker that is available in over 120 countries around the world. Bisoprolol provides effective 24-hour blood pressure control with once daily dosing. It is highly effective as compared with other antihypertensives in young and middle-aged men, particularly effective in people who smoke cigarettes, and minimal effect on lung function, metabolic parameters, and male sexual function. Bisoprolol is a treatment of choice in young hypertensive patients with additional risk factors for sympathetic overdrive, that is smokers, overweight or obese patients, diabetic patients, and high levels of stress. Thank you very much.
Thank you. Thank you very much, Dr. Zaher. Really, it was on time. We will move to the second speaker because we don't have a lot of time because of prayer of Friday. Dr. Mohammad Jabari, well-known consultant interventional cardiologist. Please, Dr. Mohammed, go ahead. Thank you.
Assalamu alaikum wa rahmatullah. Shukran, Dr. Ibrahim. I will begin immediately for sake of time. A patient with non-ST elevation MI at higher risk, almost 50% higher risk of mortality than patient with ST elevation MI. That's after 30 days after an acute event. If you see there is a ST elevation mortality almost 4.9%, whereas the non-ST elevation myocardial infarction is 7.2%. It's almost 50% higher risk than the ST elevation MI. Also, in another study, after 6 months, if you see that patient with non-ST elevation MI have a higher death rate than the patient with ST elevation after 6 months, as you see in this sloping. Also, after 1 year of discharge, the non-ST elevation myocardial infarction has a mortality rate double than the ST elevation myocardial infarction patient. The mortality in ST elevation myocardial infarction is almost 1 in 10 patients, almost 11.9%, whereas in non-ST elevation MI, it's almost 23.5%. That show that the non-ST elevation mortality is higher than the ST elevation MI. And this is the post-index discharge for a patient with non-ST elevation MI. If you see after 3 months, there is almost 33 higher risk of mortality in the arm of non-ST elevation versus the ST elevation. And after 2 years, you see there is a 60% higher risk in a non-ST elevation myocardial infarction patient than the ST elevation patients. And why that? Because mostly 8 over 10 patients with non-ST elevation myocardial infarction have a multiple vessel disease. Such multiple vessel disease patient faces a higher risk of death. If you see in the gray zone, this is a multi-vessel disease patient in non-ST elevation. It's almost 23.8%, whereas the single vessel disease is almost 11.9% in the orange one. So the mortality in hospital is triple the risk in multi-vessel disease patient, and after 5 years, there is doubling the risk, the patient with non-ST elevation versus the ST elevation myocardial infarction. Also here, we have about 1 in 5 of all acute coronary syndrome patient will suffer another myocardial infarction and another cardiovascular death or stroke within the first year. Also, this is a very important slide, that the risk of recurrent myocardial infarction was twice as high in the non-culprit lesion versus the culprit lesion. If you see the red one, it is the non-culprit one, and the yellow one, it's almost the culprit vessel. You see that the non-culprit lesion, recurrent myocardial infarction, were more likely to be in non-ST elevation myocardial infarction patient than the culprit lesions of recurrent myocardial infarction. That's why we must use the most potent antiplatelet treatment, such as Ticagrelor. Ticagrelor is the only B2Y12 inhibitors with a direct acting. Ticagrelor is not a prodrug. It does not need to go to liver, okay? This not requiring the metabolism to become therapeutic active immediately after taking the tab. Also, Ticagrelor is the only B2Y12 inhibitors with a dual mechanism of action. If you see in the slides showed that there is inhibition of B2Y12 inhibitor receptors, as antiplatelet effect. Also, there is inhibition of the ENT1 transporter. This has enhanced the adenosine response, which may result in additional inhibition of a platelet aggregation, and this leads to cardioprotective and anti-inflammatory process. And in these items, the accumulation of adenosine, this is why the causing of dyspnea is more in the arm of the Ticagrelor group. This is a very interesting and important slide that shows that Ticagrelor, the rapid and the faster onset of an inhibition of the platelet aggregation. If you see the dark blue one is almost the Ticagrelor, and the black one is almost the clopidogrel. When we compare Ticagrelor versus clopidogrel, in the first hour, you see that there is almost 80% inhibition of the platelet aggregation in the arm of Ticagrelor, in versus clopidogrel is almost 23%. Not also that only, there is also rapid onset and stability over the 8 hours. If you see, after 8 hours or 4 to 4 hours, the Ticagrelor group shown that there is almost 90% inhibition of the platelet aggregation in the arm of Ticagrelor group versus only 50% in the clopidogrel group. This is why all of you know that the Plato study shown that there is a protection at the time of the acute coronary syndrome, that Ticagrelor almost saved more lives when treated up to 12 months in compare with the clopidogrel. If you see Ticagrelor versus clopidogrel is almost, there is 21% relative risk reduction in overall cardiovascular death, and the number need to treat is almost 91. That's why in the European Society of Cardiology 2020 show that non-ST elevation MI guidelines updated that the Ticagrelor has a class 1 recommendation irrespective of the planned treatment strategy. Also here, the efficacy and safety of Ticagrelor, there is almost absolute relative risk start as early as day 30 and continue to be throughout the 12 months. If you see in the orange one, this is the Ticagrelor group, and in the black one, this is the clopidogrel. There is almost 16% relative risk reduction in the arm of Ticagrelor. Also here, what about the overall composite endpoint of the cardiovascular death, MI or stroke, in comparison between Ticagrelor and clopidogrel? Whether you will go for invasively revascularization or non-invasively. If you see the dots, this is almost antiplatelet. In the orange one is Ticagrelor group without revascularization, and in the black one is almost the clopidogrel group. Almost there is better effect than in the arm of the Ticagrelor, is almost 15% in the non-invasive group, and there is almost 14% better in the arm of Ticagrelor in a revascularization group. What about the safety and the bleeding? In the Plato, as you see here, that Ticagrelor demonstrate no increase of overall major bleeding or a fatal bleeding versus clopidogrel group. If you see the major bleeding, it's almost in the Ticagrelor group 11.6, and also in the clopidogrel group is almost 11.2. And the life-threatening or a fatal bleeding is almost 5.8 in the ticagrelor group versus clopidogrel group is almost the same. So the risk of bleeding between the two arms is almost the same. And here again, after 12 months, ticagrelor showed no significant increase in the major bleeding in comparing to clopidogrel arm. And here, prasugrel and ticagrelor reduced the ischemic event and the increase in bleeding in comparison with clopidogrel. A significant mortality reduction was observed with ticagrelor only. There was no efficacy and safety difference between the arm of prasugrel and ticagrelor. Also, in comparative efficacy and safety of the all B2Y12 inhibitors in acute coronary syndrome, in conclusion, you see that prasugrel and ticagrelor reduce the ischemic event and increase bleeding in comparison with clopidogrel. But a significant mortality reduction was observed with ticagrelor only. There was no efficacy and safety differences between prasugrel arm and ticagrelor arm. This is an important slide of the antiplatelet while you do elective surgery, when to stop every antiplatelet. The ticagrelor group is almost, you can stop it for elective surgery after 3 days. Clopidogrel almost you stop it 5 days, and prasugrel group almost 7 days. And this slide, it's very important, that showed the difference between ticagrelor and the clopidogrel in an acute coronary syndrome patient with a renal impairment. If you see, if we have a GFR almost 90, 180, there is no difference between ticagrelor and clopidogrel. But if we have worsening in the creatinine clearance and the GFR comes below 50, or a 40 or a 30, you see that there is better in the ticagrelor arm than in the clopidogrel arm. Also, regarding to stent thrombosis, there is almost better in the ticagrelor arm to prevent stent thrombosis almost in 33%. And that's shown before in the slide, that there is almost after 1 hour, there is almost 90 and stability of the 90% inhibition of the platelet aggregation in the arm of ticagrelor versus 50% reduction of the platelet in the clopidogrel arm. That's why the stent thrombosis is being a little in comparison with clopidogrel. And this is a hot topic for dyspnea. I think that dyspnea is more in the ticagrelor group than the clopidogrel, which is shown here, that the incidence of dyspnea, adverse effects, and all of us know that there is accumulation of adenosine, and this is why there is a dyspnea more than the clopidogrel arm. There is almost 13.8% dyspnea versus 7.8, which is a significant p-value. But I think we are exaggerating in stopping the ticagrelor drugs due to dyspnea. First of all, don't rush to stop the ticagrelor. As you see before in the previous slides, the most potent antiplatelet. So don't rush to stop it due to dyspnea. Try ABC. Number 1, try to take a proper history from the acute coronary syndrome patient. Sometimes the dyspnea is not related to the drug. Sometimes it's related to the heart failure symptoms or a COPD patient symptoms. This is number 1. Number 1, assess the cause of the dyspnea may be difficult in the acute coronary syndrome patient treated with ticagrelor. So we should balancing the side effect of the drug and the advantage of each single drug is needed. Only in the case of persistent and intolerance ticagrelor-related dyspnea should drug discontinued to be considered. Here in summary that ticagrelor is effective and safe in a broad spectrum of all acute coronary syndrome, in elderly patients, in diabetic, in renal impairment as you see before. What about the de-escalations? Sometimes we go, the patient has complaining of dyspnea, and this is unknowing of I think the doctors, not the patient more. The de-escalations of switching from prasugrel or ticagrelor to clopidogrel in the early phases of acute coronary syndrome has associated with the adverse clinical event at a short-term follow-up. And also the de-escalations might be safe, but associated with a higher risk of ischemic event as compared to ticagrelor. So the de-escalations from ticagrelor to clopidogrel will increase the platelet reactivity. And ticagrelor has a superior platelet inhibition to clopidogrel up to 90%. Switching from ticagrelor to clopidogrel will increase the platelet reactivity, and there is also variable platelet reactivity with clopidogrel may have impact on the clinical outcome. What about the guidelines? Immediately, recommendation of antithrombotic treatment in a myocardial infarction patient undergoing percutaneous intervention in a ST elevation myocardial infarction showed that patient with B2Y12 inhibitors, ticagrelor or prasugrel or clopidogrel, if there are not available or are not contraindication, is recommended before or at least at the time of the PCI and maintained over the 12 months unless there is contraindication such as excess risk of bleeding. This is a class 1 indication in ST elevation myocardial infarction patient. On the other hand, the non-ST elevation myocardial infarction patient, if you see that it's class 1B in ticagrelor irrespective of the B2Y inhibitors regime. And prasugrel is also class 1B, clopidogrel is also class 1B. So, the European and the American guidelines for the duration of the dual antiplatelet, whether you will treat your patient medically or invasively, you will look for the risk of bleeding. If we treat the patient medically and there is a high risk of bleeding, you will go to the European, it's class 2A, at least to give him 1 month, and the American is class 2B to give 6 months. If there is no risk of bleeding and we'll go to medical treatment, Europeans show that it's class 1 to give 12 months ticagrelor over clopidogrel, and the American class 1 also for at least 12 months. If you go with your patient with a PCI, also you will look for bleeding. If we have a high risk of bleeding, class 2A to give 6 months ticagrelor, in the European and the American is class 2B. If there is no risk of bleeding, you will continue class 1 indication to give antiplatelet 12-month ticagrelor or prasugrel preferred over clopidogrel, and thank you so much. Exactly on time.
Thank you. Thank you very much, Dr. Mohammed. 5 minutes discussion, then we will move to pray. There is a hall for pray who wants to pray, then to lunch. Thank you very much. Please, the door is open for discussion.
Thank you very much.
Yes.
Thank you very much. Very distinguished speakers in this session. زاهر الكسيح اللي هو ما شاء الله شباب، أنا تاركه من 2003، هو كان شباب والآن شباب ما شاء الله عليه، الله يعطيه الصحة والعافية. ودكتور محمد. So as we know, it is a class 1 recommendation for Brilinta or ticagrelor in acute coronary syndrome, and you are a class 1 presenter.
Thank you.
Thank you very much. My question or comment is that not only the platelet overactivity or rebound phenomena for potent antiplatelet use that cause the major adverse cardiac event, which cause the doctors and patients searching for de-escalation. It's not only the dyspnea. The side effect, the well-known side effect of Brilinta is the dyspnea.
Yes.
But there is other things, which is the price of Brilinta in comparison to the clopidogrel. This one, especially, is for the patient without insurance. The second thing is compliance of the patient because of it's twice daily. Sometimes some doctors and patients prefer to use a single drugs, especially in those with acute coronary syndrome or heart failure and many medication. These issues are important. The other thing is that many trials and meta-analysis support there is or claim that there is no big difference when do de-escalation after 1 month. What's your opinion about? You come across these things?
Thank you, Doctor. Nice question. If you compare financial causes, if you look at on the other way, that patient on clopidogrel has a little bit higher risk to develop sometimes stent thrombosis. This is number 1. In compared with the ticagrelor group. you see that ticagrelor, it's not only the dyspnea as a symptoms. I think that the dyspnea, it's unknowing for the doctors, not the patient. If you sit with the patient and explain more about that. The slide here, as you see, it's a very important slide that in comparison between clopidogrel and ticagrelor. And if you benefit the risk, if my patient develop another myocardial infarction due to using another antiplatelet agent, this is, I think, it's a more costly and more financial in compare if he's continue on potent antiplatelet.
Thank you very much. Thank you very much. Time is over. It is break time. It is break time. It is break time. Thank you very much. We finish. We can move to the pray and to the lunch. Thank you. Please,
We'll
it
discuss
is pray.
okay.
We can't break the pray. Thank you very much.